Hello and good afternoon or good morning, depending on where you are. I'm Mark McClellan, the director of the Duke Margolis Center for Health Policy and the co-chair of the Accountable Care Learning Collaborative. And I'm very pleased to welcome all of you today to a special webinar for the ACLC to introduce the Accountable Care Competency Atlas. This is a collaborative project that has been developed by ACLC members, experts from throughout the healthcare sector, and input from others as well over the past months. You're going to hear a little bit more about it now. But before doing that, I wanted to remind everyone about the ACLC and its mission, because the next slide shows the ACLC is about accelerating the readiness of healthcare organizations to succeed in value-based payment models. We found in our work in the ACLC to date that there are many dimensions to this effort. Some of them involve getting the payments and other policies right, improving benchmarks and addressing policy issues. But some of the hardest steps are in healthcare organizations themselves. Many have been well designed for their traditional purpose of delivering specific services well, focusing on excellence in particular aspects of provider care. But with accountable care, the shift is to value for patients, and that requires a more longitudinal perspective, a more patient-centered perspective, and that can be challenging. That's reflected in some of the results that we've seen in payment reforms to date, where we've had some successes, certainly measurable improvements, important improvements in quality of care and population health outcomes for patients, but also challenges in making the right investments and achieving savings and being able to capitalize on accountable care payment models that shift more of the accountability for cost, along with this flexibility in delivering care from a patient focus over to healthcare organizations. So our mission is focused on what providers should do, when they should do it, how to prioritize among these many different steps that could be taken potentially to improve care and lower costs, and how to implement it successfully and sustainably. And that's why, if we go to the next slide, the accountable care competency work is so important. The ACLC takes a collaborative approach, trying to bring together everyone in the healthcare system who does have a fundamental shared interest in getting to greater value. So provider groups, physicians, hospitals, academic experts, payers, the developers of new products, new drugs, devices, in-health services, digital technologies, contractors for some of these important services, and collaborative associations, all with this goal of furthering progress on this very important but very difficult journey to higher value care. And on the next slide, I'm going to tell you about who our presenters are today. Besides my overview and help with moderating some of the discussion and input that we're hoping to get from you later on as well, very pleased to have with us Dr. Jordan Asher, the Chief Clinical and Chief Information Officer at Ascension. We'll introduce him a little bit more later. And Valerie Overton, Vice President of Quality and Innovation at Fairview Health. But before we turn to them for discussion of the Accountable Care Atlas, I first want to introduce Tom Merrill, who works with us on the ACLC team with Levitt Partners, who is going to provide a short overview of the Competency Atlas itself. This is a public use, open source type of resource that we're making widely available. The intent is to serve as a frame and maybe a hub, really an atlas for how to get from here to there, that a wide range of organizations could find themselves on. And it's not meant to be the definitive final word. It's meant to be a atlas, one that we hope to be able to add on the resources that a range of organizations are putting together, and your own experiences in making this set of tools as useful and effective as possible in addressing, again, what I think is the most critical challenge in succeeding in accountable care and value-based care, and that's the very hard and challenging issues that healthcare organizations have to overcome to get to a successful focus on patient on longitudinal patient value and real accountability for better results and lower costs. So I'd like to turn to Tom now. Would also remind you that for those of you who are on the webinar, there's a question button that gives you an opportunity to submit questions or comments. We will have time later to discuss those, and you can submit those at any time. So please feel free. If there is something you'd like to follow up on, we'll try to get to it later on during the webinar. But right now, let me turn to Tom Merrill.
Okay, thank you so much, Mark. I'm really excited to be on in just the next few minutes. As Mark mentioned, I will introduce almost the technical aspect of the Atlas, and it will be much improved by color commentary from Jordan and Val. So to introduce really what the Atlas is, you have to go back to the beginnings of the ACLC. So this is 2016 in January. Our initial ACLC staff and research team conducted a lit review, a multi-month lit review, looking to identify all the competencies necessary for success in an ACO world and sort of in the public literature at that point. And we took the results of that work to our work groups. These are the work groups that were broken down into different domains. For example, patient-centeredness, the group that I help run, quality, governance and culture, finance, and others, who those work groups made up of the members that Mark mentioned earlier, took those competencies and refined them over a multi-month period. In gross numbers, it went from about 1,000 identified competencies down to the current version of about 160. Many of you may have seen the first announcement of that work, sort of a first draft, if you will. That press release went out last fall. We then had a public comment period for multiple months where we were able to hear from you, got a lot of improvements, and they were refined even further. At the beginning of this year, those same work groups then took the sort of condensed, sort of consolidated list of their competencies and took a first stab at creating a sequence. If you were to just do patient-centeredness competencies from maybe a committee standpoint, what would those 16 be like? What would be the order? So the work groups did that, then handed those over to what at that time was called the Master Glide Path Committee, of which Jordan and Val are a part. We selected these organizations very carefully. They are organizations that have a lot of experience in this and were able to give us sort of the frontline take. Now, a crucial piece of this is that as that group was doing their work, we partnered with Dartmouth, who has sort of helped us refine even further this, what we now call the Accountable Care Atlas, and match it up with a value-based readiness assessment that they conduct. So two very important tools coming out at the same time. We recently made this publicly available, actually just last week. We did an event at the National Association of ACOs, or NACOs, and we will now be entering a period of public comment, which we'll talk about more in a minute. So that gives you the rough timeline of how much work has gone into this. At a glance, the Accountable Care Atlas is a collection of 160 competencies, organized obviously into a logical sequence for implementation. They are organized based on relation to other competencies. So we thought that sort of holistic organization was an important step in all this, right? Rather than just a list of competencies, how do they relate to each other? Because we understand that healthcare is complex and that there's a lot of interrelatedness. And we also included, and this is what we'll dive more into in a minute, phases and work areas to help sort of break this up. And you're going to see why in a moment, why we chose to break it up. But some considerations, just because We know these are going to come to mind, so when we wanted to preempt some of them, these correspond to sort of core challenges that we faced in this work together with our members. First is when a competency is placed within the atlas, which you're about to see, it is placed to show generally when it should begin, not when it ends, which is important because a lot of these, it makes sense to continually come back to them and improve them. So just keep that in mind. Second, the phase and work areas, which you're about to see, are there for orientation's sake. They are not to dictate who should be over these things or what is the absolute timing, but they are to give sort of general direction, which we felt was important, even though it's almost impossible to pin down a strict sequence on any collection of competencies. And so third, not all competencies should even be managed by the provider. We know that ACOs are structured differently. All provider organizations are structured very differently. So in some markets, it may make sense to have a pair or other partner fulfill that need. It just sort of depends on your specific situation, which sort of all leads us into the fourth and final point, which is this atlas is suggestive. It is not prescriptive. Organizations take the atlas, review it, use it as a jumping off point, and make it fit their organization, which Jordan and Val today will give us a good example of how that could be, right? Just some thoughts. So now you are looking at the detailed version of the atlas. And the first thing you're going to notice is that this is so much. There's so much to look at here. The text isn't even legible. In fact, we don't even have this on the website yet because it's just not a very user-friendly interface. But what it does do is it shows you all 160 competencies in relation to each other. And what you'll notice first off on the left-hand side, that there is sort of this front load effect of competencies in the governance and finance work areas in sort of that pre-contractual phase in phase one. And I think that makes a lot of sense that this is sort of the prep work. You'll notice in really phase two is where most of the focus is going to be on care delivery and the HIT that supports that. It's a very powerful tool in terms of seeing these are where sort of the effort shifts may happen in our organization. So much more user-friendly is the next version, which we call the overview, where a lot of those competencies, we sort of rolled them up into a sort of broader category hexagon, as you'll see here. And so this is available on the website. You can download this. It's a dynamic PDF. And what you can do is click on each of these hexagons to sort of see what does it mean to educate providers and staff. You can click on that and it will take you to a more detailed version, which looks something more akin to this. The text is actually legible. It is something where you can see in a given phase, these are theoretically all the competencies we should be working on at the same time. So in this particular phase, there's a lot of HIT stuff versus governance, which probably happened a lot earlier. So we invite you to go to the website. Included on our website will be the checklists, which are broken out by work area. So governance, finance, care delivery, and health information technology. And we think this will be a useful tool. Another way to organize these competencies, kind of make them digestible. So I'll just finish with an invitation for all those who are watching please, or listening in, please go to the website. You can download a PDF or Excel version and comment. In the PDF version, you can make comments, and obviously in the Excel version, you can make comments. And we really invite that feedback. Our last public comment period was really fruitful. Email that to members@accountablecarelc.org, and we look forward to your input. So thank you, and Mark, I'll turn it back to you.
Let's go out.
Great, Tom. Thanks again for that overview. And again, I encourage all of you to download the atlas and give us feedback, or hopefully start to apply it in your own organization as well. Before I introduce or turn to Jordan and Val, I just would like to spend a minute thanking them and the other healthcare leaders who put in a lot of time and effort to put this kind of comprehensive competency atlas together. You can see on this slide the leaks from the healthcare and the accountable care industry. People are actually involved in working through the development and application and successful use of these competencies who helped guide the overall work. Our Accountable Care Atlas Committee, which includes Jordan Asher and Val Overton, along with others who have had long experience in this field. As you heard from Tom, and it shows on the next slide, our work was divided into a set of work groups focusing on these major categories of competency. These people, including Joel Rich, Jeff Lyrick, Karen Bell, Bruce Bagley, Todd Allen, and Michael Millinson, also put in a lot of effort working with a much larger number of participants in each of our work groups to make this really, in many ways, a crowdsourced type of approach. So these are some of the contributors into the overall effort. What I'd like to do now is turn to Jordan and Val for some of their initial thoughts about applying the Accountable Care Atlas, as well as any reflections they have about the process used to develop the Atlas and its potential further development. As I mentioned briefly before, Dr. Jordan Asher is the Chief Clinical Officer and Chief Information Officer for Retention Care Management. And Val Overton is the Vice President for Quality and Innovation at Fairview Health. We're first going to have some initial comments from each of them on these general topics related to the Accountable Care Atlas, its formation and need, and its potential application. And then we look forward to any comments or questions that you all may have. Again, you can use the button towards the bottom of the webinar window to send those in. And also, we'll have a little bit of time for discussion with them after their initial comments. So, Jordan, let me turn to you.
Sure. Thanks so much, Mark and Tom and Val. And first of all, I'd like to say thank you for including me on this call because I think this work is great and incredibly important. I feel very honored and blessed to not only do what I do every day, but to be part of a larger organization, the collaborative, that is really focused on how do we get better at what we do. Because at the end of the day, all our goal is to take care of those we serve better and help those that we ask to serve to do it better in a methodology that creates greater value for those we serve. And so I want to take a few minutes and sort of give some overall comments of not only the Atlas itself, but really as we designed it and worked on it, how to think about its uses. Because I think we all have been bombarded with lots of information about how to do what we do better. And historically, I have found that to be more high level and helpful, but really I'm an internist by trade, so more like the Harrison's book of internal medicine, which is the big volumes. But every day when I had to go into the hospital, I had to do my daily work and I had to use something that I could pull out and use and really help. And as we all know, we are on a journey. So I really love the term of this being an atlas because it helps us along our journey. And as we all are along our journey, we're all at different places on that journey. And we all don't have the luxury of starting at point, phase 1 or 0, because we've all been thrown into different situations. So I began our journey back in 2011 with one other person, basically being asked to create a population health management company in Nashville, Tennessee called Mission Point Health Partners. And then over the past 6 years, that has grown to being sort of the tip of spear for Ascension, and now managing lives in value-based arrangements in 7 different markets in 7 different states. So even though, Mark, you mentioned some of us have been doing this for a while, I still feel very young, not only in what we do, but also in the whole ecosystem as it revolves around the shift to value. And so therefore, I really came at the work we did on this and lots of people, as Mark mentioned, did great work. And luckily, I was able to come in and just sort of help think about it from the external perspective and putting it all together, but really looking at it from two components. As I thought about, there would be people needing to use an atlas or a tool like this that were A, just starting out, but also B, midstream. Because we all, I'm sure, feel like we're trying to change the tires on an airplane while it's in flight. So how could we design it and then use it regardless of where you are on your journey? So one of the big values that I'm seeing around this competency atlas is to get a sense of where I am. So I could look at it and say, wow, okay, this is where we are, and in the different categories, and boy, I am sort of in different phases at different times. And I find it very helpful to use this type of tool to help the leadership of any organization to say, okay, here's the overall ecosystem, here's the interrelationships of the different components, and how do we have to make sure that we don't skip really important ones? How do we make sure we understand what the problem is we're trying to solve and solve that problem, and not, for instance, fall in love with a solution that is really a phase 3 component? So really using it from a leadership and organizational development perspective to really outline what is going on. And then for those of us that have been on this journey for a while, how to get a sense of where we are. And are there ones that we need to go back and redo or do better? So even though this is built out in a linear fashion, I tend to think about it as having connections backwards as well, because as we take a step forward, we also have to look backwards to make sure we did do all the correct steps, or steps that needed to be done that are foundational, and that we continue to optimize those steps as we move forward, especially as it comes to leadership and change, because this is transformational and we all have to manage that change. So getting a sense of where we are, and then where do I have to go back and really look at it. And then thirdly, the other third sort of key point that I have found very helpful is, what are the interdependencies between these? Meaning, have we missed not only a competency, but have we missed the link of how it relates to another competency? And if we have missed that link, have we set up silos that work on each of those and missed bringing those together? Have we done something without taking a different competency into account, based on the fact that there are interdependencies and that the map shows where a lot of those dependencies are? So for me, I am finding this very helpful, and hopefully will be very helpful to others, regardless of where they are in their journey, to get a sense of where they are in the competency map, use it to help the leadership and organizational structural design of however you are setting it up, where those interdependencies are, and do I need to go back and continuously, and how do I go back and continuously look at it, make sure I did not miss things, and optimize those areas that have come before from a competency perspective. So I think I'll stop there, and Mark or Val, I'll let you all take it away.
Great, thanks, Jordan. I'd like to turn to Val now.
Hi, I just want to do a quick sound check. I'm having a lot of static on my side. Is everyone hearing me all right?
You sound great.
Pretty good.
Oh, okay, great. Well, you know, Jordan, I wanted to just resonate with what you were saying as we were prepping for this presentation. It was really interesting to share emails with Jordan and see how much we really saw the Atlas's values similarly, given our different experiences in organizations. So I really appreciated Jordan's comments. And I too wanted to thank the folks at the ACLC for the experience of being on this journey. I participated in the patient engagement, patient-centeredness work group, and it was really quite a eye-opening and enjoyable experience. I am Vice President of Quality and Innovation here at Fairview Health Services, and just a little bit of context, we began our journey from volume to value in about 2010, I was involved on the front lines with the transformation work at that time. And that was part of the perspective I was representing in the work group and then in the master group that was bringing everything together. And back in 2010, we said at Fairview, we're not sure what this journey looks like. Jordan referred to it very aptly as a journey. We're not sure what this journey looks like, but we're on the path, and we know it means we're going west. And that is about as good as we really understood what the entire journey would be like in 2010. And in fact, many of us have heard leaders across the United States talk about when you've seen one ACO, you've seen one ACO. And so given that experience here at Fairview of really just launching out into a journey and really not having a map or an atlas, and that idea that ACOs differ so much from one another, I find that the atlas is quite in really giving guidance, having signposts, goalposts, if you will, in the phases, and helping the journey not to feel as diffuse and undefined as it might have for some early adopters of this work. So in the powerful picture that's on the screen right now, I think it really does help leaders engage across the organization when they talk about either at the board level or with clinician groups and so forth, to say this really is the picture of the journey we're on. This is what it looks like. And we can dive into a lot of detail around tasks, but at a high level, bird's eye view level, this is what it looks like. Really powerful tool for engagement across the organization. I think there are clear inflection points where that high level view of the work you're doing is really important. It ends up being important when an organization makes a strategic decision to embark on a journey to become an ACO. There are other inflection points, and here at Fairview, we're going through some of them right now, where we're integrating another organization with ours, and so we're going back to the foundations of governance, finance, care delivery, and health IT, and understanding as we come together with our strengths in the two organizations, how that's going to impact this journey and where we may shore up the work or borrow strengths from each of the organizations to come to an integrated whole. So you can imagine several inflection points where the atlas may be helpful in an organization's life cycle. I think one other inflection point that I would like to really point out is anytime an organization may be choosing what type of program to embark on, the type of ACO, how much risk in Medicare shared savings, for instance, versus a program like Next Gen ACO or other, say, Medicare Advantage type arrangement. It's an inflection point, again, strategically to go back to the atlas and see where the organization is at. I think just to say one more piece from the front lines and organizations that are in the middle of the journey, we at Fairview, like similar to what Jordan mentioned earlier, are going back to our foundations and looking at pieces that will shore up, looking at competencies that we might have missed, and trying to cascade that work down and across the organization as we're on the journey. That is a much easier task to do and align across the organization with an atlas like this. We're more easily able to point out to the various stakeholders across the organization where the work needs to be done, rather than have theoretical discussions about what's really important for an ACO. The guideline really can be helpful for alignment. So I think those are the main comments that I would have at this point, really echoing Jordan's comments, and look forward to questions and discussion. And Jordan, I don't know if you have any further.
Yeah, Val, you mentioned something I do want to reiterate and make a comment about the moving to risk-based arrangements and how this is sort of outlined as a pre-contract phase 1, phase 2, and phase 3. For those of us on the call that lived through a direction in the 90s, I'm not going to even give it a name, one of the things that happened was many people jumped into risk much quicker than they were able to handle. And so one of the things that this helps me remind myself is that the movement to value and the movement to risk-based arrangements are really two different movements. And where this is very helpful for me is to remind me of that fact and what I need, not only from a care perspective, but from a contractual perspective and a governance and structure in order to be able to not only take the risk, manage the risk, but to take the risk. And we all have to think about what we do in the movement to value. And as we think about risk, how do we take risk? How do we manage risk? And then most importantly, how do we deliver greater value to those we serve? So thank you, Val, for bringing up that point.
Yeah, well said. Thanks.
Great. I'd like to thank both of you for the comments, and especially for all the contributions to the Accountable Care Atlas effort, and also for the hard work that you're doing on this journey. I appreciate the way you pointed out that, despite the challenges of the journey, it's much easier to make sure you're getting to the right place and have the capacities you need to succeed if you've got an atlas, and that's exactly what this effort is intended to fill in, as you all eloquently pointed out. But I would say, even though you said you all emphasize that you're still on the journey, you all have been leaders in this area for a while, and maybe just one initial question, and then we'll turn to some of the other topics that have come up and questions that have been raised. There are a range of organizations out there in terms of the scope of activities that they undertake, as well as where they are on this kind of atlas framework, on where they are in this journey. Could you all say a little bit more about, kind of based on experiences that you've had, does this atlas seem like it would apply to, say, smaller groups, primary care organizations, specialty groups, as well as larger systems that are or aiming to be more integrated and consolidated providers of this whole spectrum of care? We had a lot of discussion, accompanying documents around the decisions about doing things yourself versus partnering, and that's something that Tom brought up early on in today's discussion as well. So I think, Jordan, this goes along with your last comment about managing risk versus delivering value-based care. Could you all say a little bit more about diversity of organizations that this atlas might apply to, or why it might be more or less applicable in different contexts?
Sure, and Val, I'll take a first stab at that. And so I think it's a great point, Mark, and I think it's an important question because as we all are different, we really didn't want to design something that only fit one situation. So as I look at the atlas, I also, even though we are fairly big, we always go through that discernment of, do we build, do we buy, or do we partner, right? So that's a continuous question we have, especially as we think about risk. And I think what this atlas helps me even think about at our stage of what categories do I put certain things into. And so therefore, it helps me decide where I might want to partner instead of where I might want to build or buy. Where am I very strong? And boy, here's a bunch of other competencies I didn't even think about that I need to decide, do I need to get strong at, or do I need to find a partner to partner with? Now, I do believe that some of these are foundational regardless of your size, especially as you move further left around, governance and change management. I think that is true of any organizational size. And in fact, sometimes that's easier the smaller you are. So I definitely do believe that this atlas can be used to help answer the question of, my gosh, this is so complex. There's no way I can do all this. Therefore, I shouldn't start at all, versus answering it differently. Okay, I see what the competencies are. I see what the needs are. How do I think about it from the context of what are my strengths? Who do I partner with? What do I bring to a partnership, right? Because a partnership is two different people or two different organizations. And it helps me understand where my strengths might be, whether I'm a provider, a payer, regardless of what I am, where I truly have what would I bring to the partnership and what I need out of the partnership.
Yeah, exactly. And I think another way in which the Atlas can help with this concept of do I build, partner, et cetera, is often organizations also are dealing with a very large amount of complexity in their partnerships, where potentially part of the organization is very advanced, part of the organization may not be as advanced, depending on the partnerships that you've cobbled together. And the Atlas just helps you clearly assess the variability in those partnerships in a way that I think the clarity of the Atlas itself can help prevent you from getting stuck in too much complexity, where you're trying to balance, is it a competency that's important, is it not? And now I have all this variability across my organization. How should I think about that variability? A much more clear-eyed assessment of where your organization is at.
Yeah. Well, that all makes a lot of sense. And I want to bring up a follow-up question that's come up. As we, and maybe you've already answered this in part, but as you look at this detailed overview of the Accountable Care Atlas, there's a lot on there. On the other hand, as you all pointed out, healthcare and other prominent people have noted, healthcare is complicated. And I think one of the things that is very difficult about doing this work on the ground, as well, it seems like there might be a lot of resources out there. Jordan, as you were saying earlier, maybe they're too high level for what you need, or too much detail to go through. The Atlas was certainly formulated trying to find that middle ground that you all are describing. But is there anything, as you've gone through this process, what's missing? Or there's some things that we've learned, or ways that the Atlas can usefully be combined with other kinds of tools and resources that you all may have thought about? I mean, maybe it's just, Jordan, as you were saying earlier, and Eric, both of you were saying, this is a good way of making sure you're not missing things that are important and helping you focus your current efforts on key issues for your stage of development. But I appreciate your further thoughts about whether what is missing, and whether there are other tools that might be useful to think about pairing with the Atlas, or experiences to build on.
I think what would be missing if we stopped here. So as both, I think Val and I talked about, this is an ongoing journey which requires ongoing learning and education. And so that requires us to study the competencies and to see what makes sense and what doesn't make sense and what might need to change. So that's what excites me the most, is the fact that we're not talking about an atlas by itself of 160 competencies. We are talking about it within the framework of a learning collaborative, right? So not only the members of the collaborative, but us all in healthcare. So you talked about, Mark, the connection with Dartmouth on the research side. We're not even sure what we'll find comes out of this, right? And then then I'm not sure was mentioned around the educational piece from WGU and the relationship there, because as we all know, at least what we're finding, finding the people that are prepared to deliver the new type of care that we're going to be needing, that's a workforce development issue. And so that's one of the things that's not, for me, is not on here to the same extent, but we're trying to solve for that within the collaborative as we think about, okay, what do we find here that we need to create something else? Workforce creation might be one. Study design might be one, because now we're moving lots of variables at the same time. So it doesn't fit well with the old, perfectly randomized controlled trials that I'm used to as a scientist. And so that to me is, I don't really think anything, what is missing is what we don't know. And I think we have solved for that in how the overall program is designed.
Yeah, I would agree. I'm not sure that there's any major portions missing, but I think the tasks are both specific enough on the Atlas as you dive in to give you a real sense of the real work that needs to be done. And the Atlas is general enough and high level enough that I think it encompasses some of the things that will be coming toward us soon, like more community partnerships, workforce development, as Jordan said. I think we have developed an architecture that is broad enough and high level enough to encompass those things. We may see some of the tasks shift and change over time as both technology and the healthcare system in the U.S. itself begins to evolve and change.
Yeah, well, I appreciate both of your comments, and it does sound like an important use of the Atlas is to help shape what might seem like a complex and poorly understood frontier as organizations are moving forward to try to succeed in these models, and to a journey that's maybe challenging but much more manageable, and people are equipped with the tools they need to make it effectively. Before we close out, I did want to ask you one more kind of bigger picture question about where we're headed. So I think it's fair to say that this transition in the U.S. healthcare system to focus on value has been challenging for organizations, challenging for engaging patients and consumers, challenging from the standpoint of policymakers getting it right. And we're also operating at a time when there are other things going on. Some of the reforms that are being discussed, or potential reforms in the ACA, maybe further changes coming in Medicare and Medicaid and other public programs. You all have maintained a focus on moving forward with value, even with these challenges in the environment. So I would appreciate any final thoughts you have about where we are collectively on this journey, how the Atlas can help, and why you feel like it's such an imperative to continue with this work, even though it may not be completely clear what exactly is going to happen next on ACA coverage or Medicare payment reform models, or any of the other big influences on the healthcare system. Just any final thoughts about where we're headed and the importance of getting this journey right?
Yeah, for us, why we do this is a healthcare organization. Our mission basically calls us to do this exact work. So as we look at our mission of helping individuals and communities, especially those that are poor and vulnerable, and doing it in a socially just way, the move to value basically is our imperative. And so even though this work might be hard and it might be easier to do other things, it is part of our calling as an organization. And therefore, we don't, saying in a different way, we don't have a choice. And so that's why these types of discussions and help is so important to us, because it helps us deliver on our mission. Pretty clear and simple.
Yeah.
Yeah, I would agree. Yeah, I would agree with that. And again, as you try to execute on the mission, Fairview as well is a mission-driven organization in the same way as I think most healthcare organizations are. But you can't have a mission unless you have the funding. And so again, back to sort of the value of the Atlas. In our journey at Fairview, we did get out over our skis a couple of times with the development of our infrastructure to take risk and do value-based care. As healthcare in the United States changes ever more rapidly, having at least this type of map to, again, have a clear-eyed assessment of where your organization is at, and be able to take into account anything that the Washington, D.C. might put in place is just a real value to an organization that wants to continue to live its mission. Really, really valuable.
Yeah,
well, again, I want to thank you.
And Val, you said it great, how we would use this to not only try to prevent us from getting out over our skis too far, but when we're out over them too far, how we get more upright. I really
how to rebalance. That's right. Well, I know Governor Levitt, my co-chair in this effort, would very much appreciate the skiing analogy as well. So I want to thank both of you again for the work on the contributing to this Atlas, which is going to be a dynamic and growing document as we chart out this territory, hopefully ever more effectively. I want to thank you for the time today on this webinar to help introduce the Atlas to a broader community. And I want to thank you as well for your commitment to mission. I completely agree that that's what makes healthcare special and distinct. That's why it's so important to the American public, and it's also why we really have to get this right. As you all said, this is an imperative. I wish it were easier, but it's terrific to see the community that's coming together around solving the challenging problems of focusing on value and doing it in a way that is a sustainable and practical and hopefully growing business model. Before I wrap up, I just want to say a couple of final words about the Accountable Care Learning Collaborative. As you heard from Jordan and Val, this is not the only or final product of our effort to try to advance value-based care. We will be working hard with a range of other organizations and partners to link in additional resources that help flesh out these competencies and help organizations find the right place to turn at the right time for additional help or resources. I think Jordan mentioned not getting distracted by particular solutions that look bright and shiny but may not be solving your most important problem at this time. But there are a lot of resources out there that link to the Atlas, could be very helpful in doing that. So more of that coming in the ACLC. Jordan and Val also mentioned the value-based readiness assessment work that ACLC is undertaking with partners like Dartmouth and help from Duke on enabling organizations to see where they are and helping us develop more of a database to compare where you are to others and again help flesh out the Atlas framework. Related to that, the ACLC will also be supporting further research to strengthen the competency framework to demonstrate how particular competencies or combinations of competencies can work well with different kinds of risk arrangements and can achieve important organizational goals around outcome improvement and and cost reduction. So more collaborative work coming in the research area too. And then finally, we mentioned additional workforce to help the leaders involved in this care undertake these efforts as efficiently as possible with the involvement of WGU, other partners, Duke and Dartmouth as well. So we hope if you're interested in further work or contributing or collaborating on these efforts to move down this journey to value-based care as effectively as possible. We'll hear more from you at the Accountable Care Learning Collaborative. We have more webinars and other meetings, resources coming up soon, and we look forward to staying in touch with you, or if you're not working with the ACLC already, more information is available at info@accountablecarelc.org, or just Googling the Accountable Care Learning Collaborative on the web. Thank you all for joining us today. Thank you all for contributing to and keeping a commitment to this very critical shared mission of getting to value-based care. And have a good rest of the day.